Hey guys, this is the lecture for chapter 25 and 26, and we're going to be talking about complications that can occur because of pregnancy or complications that we can have because of existing conditions. So, one of the first complications we're going to talk about is spontaneous abortion, and this is just where the body rejects the fetus for some reason. It can be chromosomal, it can be metabolic, it can be a lot of reasons why the body decides to get rid of it. But, it does this usually before the fetus is viable. So the fetus would not be able to live outside of mom if it were born at that time. So, usually what we want to do for women who have a spontaneous abortion is, of course, prevent complications from shock, because you can have a lot of blood loss. You could have infection. And we also need to make sure that we support them because, this was going to be their child, and so they're going to be upset that they've lost their baby. And especially if this occurs more than once and the woman is having trouble conceiving, this could be an ongoing problem that we would have to deal with the grieving process over a long period of time. So, types of abortion. The first one really is threatened. This is where we have vaginal bleeding, and most pregnant women have vaginal bleeding. But we need to make sure that the women who do have vaginal bleeding, that they let the physician, the healthcare provider know, because usually about half the time these embryos and fetuses will not survive. Inevitable means that the membranes have ruptured and there is active heavy bleeding. So, with the inevitable, it's going to happen. We can't stop it. The main thing we want to do is make sure that if there is any remaining tissue from the aborted fetus or embryo, that we get that out, because that can cause infection. So, with the inevitable, we can have incomplete and complete. Incomplete just means that not all of the fetal tissue is expelled out of the body, so they would have to have a D&C, dilatation and curettage, in order to remove that remaining fetal tissue. A complete just means that all of the tissue is expelled and there's no need for any intervention. A missed is a form of abortion when the fetus dies, but it's not expelled from the body. It's retained inside of the body, so none of the components are expelled. And then recurrent just means that the female has had 3 or more spontaneous abortions. Usually there is some type of genetic chromosomal defect or a problem with the female's reproductive tract. Also, it may just be that there's a problem with the cervix, and the cervix isn't closing up and tight enough to hold the fetus in the uterus. And so sometimes we can just put a stitch into the cervix, and it helps hold everything in there for the term of the pregnancy. And then once it's time for the baby to be born, then they can actually cut that stitch, and then the baby can be born. So this is just some examples from your book talking about the threatened abortion. We do have vaginal bleeding. Inevitable is when the membranes rupture and the cervix dilates and it's expelling the fetus. And then incomplete just means that there's just part of that fetal material left inside of the pregnant female. Okay, ectopic pregnancy, and this is when the fertilized egg implants somewhere other than the uterine cavity, and usually it's in the fallopian tube at some point. The incidence of ectopic pregnancy is increasing as a result of pelvic inflammation. So what we want to do is we want to make sure there's not hemorrhage, and we want to try to preserve the fallopian tubes so that the female would be able to get pregnant again. So some risk factors associated with ectopic pregnancy include IUD use, anatomical or functional defects of the fallopian tubes, a history of STDs, failed tubal ligation. Maybe mom had her tubes tied and they didn't do a really good job, and so that's why you had that implantation outside of the uterus. Or if you have had multiple induced abortions, and this is a an abortion where the female decides she doesn't want the baby, and so she aborts or has an abortion of the baby, so she will not be pregnant anymore. So here are just some sites of ectopic pregnancy where they can occur, and depending on where they occur, they're called something different. Okay, gestational trophoblastic disease, and basically this is a tumor that grows inside of the uterus. So what happens is a trophoblast develops abnormally, and these are the cells that attach the embryo to the uterine wall. So the placenta develops, but not the fetus. So a complete is when the ovum is fertilized, but only the sperm component multiplies. And then an incomplete or partial is where the maternal component is present, but the paternal contribution is double. So instead of having a diploid set, you've got a triploid set. So the baby would have 69 sets of chromosomes, and then either an XXY or an XYY, depending on which sex the sperm was. So this is just an example. It shows you there is no fetus. It's just the placenta. Usually what we do is we evacuate the mole, and then we follow up to detect if there's any malignant changes, or if there has been some cancer developed from this abnormal cell. Okay, some of the hemorrhagic conditions of late pregnancy. The first one is placenta previa, and this is where the placenta previa presents with painless vaginal bleeding during the last half of the pregnancy. Now, there are different grades depending on the relationship and distance to the internal os. Now, your book only says they're marginal, partial, or total, and it's really all you have to know, but I'm going to tell you a little bit more. Grade 1 is a low-lying placenta. That means the placenta lies in the lower uterus segment, but its lower edge does not abut the internal cervical os. So it doesn't touch the internal os. Grade 2, which is the marginal, the placental tissue reaches the margin of the os, but it doesn't cover it. A grade 3 is a partial previa, and this is where the placenta partially covers the os. And then grade 4, or complete or total, means that the placenta is completely covering the internal os. So what are some risk factors that are associated with placenta previa? If you've had a placenta previa before, if you've had a cesarean, if you have an increased maternal age, you have increased parity, which means that they've been pregnant a number of times and they've had more than one child at a time. Large placentas that are a result of multiple gestations or erythroblastosis, and also a history of smoking. So the next thing that we're going to talk about is the placental abrupto or abrupto placentae. You can have bleeding that is visible or concealed, so they may have visible spotting that's actually coming out of the body, or you may see other symptoms because the bleeding is occurring inside of the abdomen, inside of the uterus, and so you may have pain or tenderness that you can't explain because they're not really having any other bleeding. So usually the direct causes are rare, but can include like an injury to the belly area, such as a fall, a hit to the abdomen, or a motor vehicle accident, or a sudden loss of uterine volume. And this can occur with rapid loss of amniotic fluid or after the first twin is delivered when you have multiparity. So what are some risk factors for abrupto? Blood clotting disorders, smoking, cocaine, diabetes, drinking more than 14 alcoholic drinks during 1 week during pregnancy, high blood pressure, a history of having placenta abrupto before, increased uterine distension that may occur with multiple pregnancies or with a very large volume of amniotic fluid, a large number of past deliveries, an older mom, premature rupture of membranes, and you may see this as PRM, and that means premature rupture of membranes, or ROM, which is rupture of membranes. So premature is when the water breaks before 37 weeks into the pregnancy, and then uterine fibroids. So placenta abruption, which includes any amount of placental separation before delivery, occurs in about 1 out of 150 deliveries. The severe form, which can cause the baby to die, occurs only in about 1 out of 800 to 1,600 deliveries. So some symptoms of abrupto is abdominal pain, back pain, frequent uterine contractions with no relaxation in between, and then vaginal bleeding. So this right here is just showing you the placenta previa. You can see the marginal. The placenta is really low in the uterus, but it does not touch the os. In partial, it does touch the os, but it does not fully cover it. And then in total, the placenta is completely covering the internal cervical os. And I hope everyone knows that the internal cervical os is where the baby has to come out. Okay, so this just shows you some of the abrupto placentae. You can see with the marginal, we have some external bleeding. With the partial, you may have concealed bleeding. And then with the complete, you could have concealed bleeding as well. So we would have to look for those symptoms that are more abdominal in nature, the pain, the tenderness, things like that. Okay, the next disorder is disseminated intravascular coagulation, or DIC for short. This is a life-threatening condition in which blood clots form throughout the body's small vessels, and these blood clots can reduce or block the blood flow through the blood vessels, which can in turn damage the body's organs. So in DIC, the increased clotting uses up platelets and clotting factors in the blood. Platelets are blood cell fragments, you know this, that stick together to seal up cuts, things like this. So if you don't have as many platelets and clotting factors in the blood, then this can cause serious bleeding events, and it can be internal or external. So we know that internal, that's inside the body, and we may not be able to see it. And then external bleeding occurs underneath or from the skin or the mucosa. So what are some conditions that can cause clotting factors to become overactive that could lead to DIC? These would include sepsis, which we know is an infection in the bloodstream, surgery or trauma, cancer, or serious complications of pregnancy and childbirth. So some less common examples may be a snake bite from a poisonous snake, frostbite, or burns. So as a nurse with managing DIC, we're going to be monitoring vital signs. We're going to be assessing and documenting the extent of hemorrhage or thrombosis. We're going to be correcting the hypovolemia that has occurred from the hemorrhage. And we're going to be administering basic hemostatic procedures when indicated by the physician. So here are some signs and symptoms of a concealed hemorrhage in abrupto placentae. You have an increase in fundal height. The fundus is being pushed upward because of the blood that is accumulating inside the uterus. They're going to have a hard, rigid abdomen, and that is once again from that increase in blood or fluid inside the uterus. High uterine baseline tone, persistent abdominal pain. We're going to see signs and symptoms of early hemorrhage. We may see persistent late decelerations with baby's heartbeat. And there may be vaginal bleeding that is slight, but then it may not be any vaginal bleeding at all. So monitoring for signs and symptoms of hypovolemic shock, of course, we would have an increased pulse rate, but a falling blood pressure. We would have an increase in respiratory rate. We may have a diminished peripheral pulses. Our skin may be cool, clammy, cyanotic, which that is a late sign. We're going to hold on to all of our fluid in our body because we're bleeding somewhere and we don't have as much volume, so they're going to have decreased urine output. We're going to see a decrease in hemoglobin and hematocrit. And because we don't have enough circulating blood, that means there's not going to be enough oxygen getting to all of our organs, especially our brain. So you could see changes in mental status with this. Okay, hyperemesis gravidarum. This is persistent, uncontrollable vomiting that starts in the first weeks of pregnancy and continues. It doesn't go away in the second trimester. So what we have to do is we have to manage mom. We have to prevent dehydration, because if she's throwing up, she's not going to be drinking a lot. So she's going to have dehydration. She's going to have electrolyte imbalances. If she's throwing up, she can't eat, so she's going to have malnutrition. Our goal is to reduce the nausea and vomiting, and also to support that mom, because she's going to be under a lot of stress being sick like this and knowing she can't provide the nutrients and the fluids that the baby needs to grow. So only about 3% of pregnant females get this disorder. This disorder is associated with small babies, and also babies that deliver before 37 weeks. So some drugs that we might use with mom would be things like Dramamine, and that's over the counter, Reglan, Phenergan. And usually we can't use these drugs until after 12 weeks because of the development that's going on in the embryo/fetus that can cause problems. And we also may use proton pump inhibitors and H2 receptor antagonists to try to prevent some of the problems with the sickness, the uncontrollable vomiting. Okay, preeclampsia, and I have put on Blackboard a patient information sheet that is several pages long, but it basically gives you an introduction to the 4 major causes of hypertension, which occurs during pregnancy, what preeclampsia is, and what are the general guidelines that we see, who's at risk, what causes it, signs and symptoms, care, how it's treated. All of that stuff is in that handout that I want you to look at. I'm going to generally go over it, but more in depth you can look at that handout. So basically the pathophysiology is generalized vasospasms decreases circulation to all of the organs in the body, including the placenta. So the liver, kidneys, and brain are all affected. So how do we treat women with preeclampsia? Well, a lot of times they're on bed rest. We reduce external environmental stimuli, and we may have to give them anticonvulsants to prevent seizure activity. You're also going to see edema, especially in the lower extremity, and you can see this mom has pitting edema in her lower extremity. So with mild preeclampsia, home care, they're not going to be in the hospital, but they are going to have activity restrictions. They probably are not going to be able to work unless they work from home on a computer. So they may be on bed rest at home. And remember, guys, if you're on bed rest for 3 months, it gets really boring, and you start feeling like you are going crazy staring at the four walls. So we have to remember things like that mom is going to have a hard time trying to sit still, especially if she has other small children living in the household. So if that were to occur, then we've got to see what kind of support she has at home so that she can get her bed rest, because if she can't do her bed rest at home because she's got 2 other small children, then that could cause her to have to be into the hospital. Of course, we're going to monitor fetal activity. We're going to look at her blood pressure, weight, urinalysis for protein. She is going to be on a no-salt diet, and then we're going to do fetal surveillance as well. So eclampsia basically means seizure. So we use magnesium sulfate to prevent seizures in preeclampsia, to keep it from going to full-blown eclampsia. So we have to monitor the patient and make sure that the medication we're giving them is effective. We also want to control external stimuli and help protect mom in case preeclampsia proceeds to eclamptic seizures, because remember, most injuries with seizures occur when you fall to the ground or you fall to the floor, and we wouldn't want mom to fall on her belly and then possibly cause injury to the fetus. Just like with anyone else that has a seizure, and we've learned about seizures, we want to try to maintain safety. We don't want any injuries to occur. We would stay with mom. We would turn her on her side, and we would keep track of how long the seizure lasts, because these are things that the physician is going to want to know about. Of course, airway is a big thing. We want to make sure that after the seizure that we maintain their airway. That's one of the reasons why we turn them on their side. We may need to suction them if they have a lot of secretions. We want to give them oxygen. And then we would want to observe fetal monitor patterns for any signs that baby might be hypoxic as well. Alright, so a question. Magnesium sulfate is a treatment for eclampsia for what reason? To improve nutritional status, to reestablish electrolyte balance, to prevent seizure activity, or to dilate airways and improve respiratory efforts? The correct answer is C. We use this to prevent seizure activity. Okay, our next disorder is hemolysis, elevated liver enzymes, and low platelets, or HELLP, H-E-L-L-P. It is a syndrome that occurs as a result of the fragmentation and distortion of red blood cells when they're going through damaged blood vessels. So what happens is liver enzymes levels increase when hepatic blood flow is obstructed because of these little fragments of red blood cells. And we have low platelet levels that are caused by vascular damage resulting from vasospasms. Also on Blackboard, I have put a handout on HELLP syndrome. It actually goes through and tells you what it is, the symptoms to look for, how we treat, what can we do to prevent, how it affects babies, and the risk of this occurring again if you get pregnant in the future. So look for that on Blackboard. It should be labeled HELLP syndrome. So we also have to remember that women who have chronic hypertension are at increased risk for having preeclampsia. So because of this, we have to monitor moms with a history of hypertension very close and make sure that their blood pressure is being maintained at a good level. So they may be on antihypertensive medications, and we would want to make sure that we keep the blood pressure low and that the blood pressure medicine does not have any implications for causing fetal anomalies. Alright, the next problem that can occur is the Rh incompatibility, and this is when an Rh negative woman conceives a child who is Rh positive. And what happens is that antibodies, mom develops these antibodies after exposure to the Rh positive fetus, and it normally doesn't cause problems with that pregnancy, but it will cause problems in future pregnancies. So when we have an Rh negative mom, usually at 28 weeks, we go ahead and administer RhoGAM to help prevent any problems from occurring. Another problem is ABO incompatibility, which is when we have an O blood type woman, and that woman has naturally occurring and anti-A and anti-B antibodies, and so it can result in hyperbilirubinemia in the infant. And this is just the example from your book that shows what happens when you have an Rh negative mother and an Rh positive father, and what happens through the stages, and then afterwards when she gets pregnant again. Okay, so Chapter 26 talks about diseases and disorders that were present in the female prior to getting pregnant. An example of these is hypertension and diabetes. So, effects of pregnancy and fetal metabolism. So, episodes of hypoglycemia may occur during the first 20 weeks of pregnancy. And that's because pregnancy causes females to be insulin resistant. So after 20 weeks, normally this is when we start seeing this resistance to insulin in maternal cells, and maternal insulin needs will change throughout the pregnancy. So early in pregnancy, there's not a lot of changes, but with morning sickness, you can have hypoglycemia. And then late in pregnancy, we talked about that insulin resistance occurs because the body wants to have more glucose available in order to supply the fetus with the glucose that it needs in order to develop and grow. Okay, so women who have type 1 diabetes have a greater risk for preeclampsia, infections, and ketosis. Maternal hyperglycemia during the first trimester increases the risk for congenital anomalies. So our goal is to make sure mom has blood glucose levels under control even before she gets pregnant. And this will help with management throughout the pregnancy and hopefully decrease the chances of these congenital anomalies. So, how does this affect the fetus? Well, the fetus can't grow if it doesn't have enough glucose. So, mom has to have a lot of glucose in her blood. So, in addition to congenital anomalies that can occur, the infant of a diabetic mother is also at risk for hypoglycemia, hypocalcemia, hyperbilirubinemia, and then respiratory distress syndrome. Because remember, if baby is in mom and that's a really rich glucose environment, and then all of a sudden baby's born and we cut the cord and they no longer have access to all of that free glucose that's floating around, then baby hasn't been producing enough glucose and can't sustain itself once it's born. So, gestational diabetes is exactly, what it says. It's an increase in blood sugar that happens in a pregnant female. And we see this most often in pregnant females who are between the ages of 19 and 40. So what we would like to see happen is that we've got preconception care, and mom can find out, number one, if she might be at risk for gestational diabetes, but that a lot of times gestational diabetes doesn't have any symptoms. So we want to make sure that mom's getting good prenatal care and preconception care so that we can be on the lookout for this. So we talked about risk factor, and usually, women who are greater than the age of 25, if they have a personal or family history, if somebody else, your mom or your sister, had gestational diabetes, you're overweight, and for non-Caucasian ethnic groups such as Hispanic, American Indian, Asian, African American. So, women who have gestational diabetes can deliver normal, healthy babies. Okay? This is not going to happen with everybody who has gestational diabetes. But it can cause problems, and it can increase the likelihood that you might need a cesarean in order to deliver your baby. So, some things that can happen to the baby with gestational diabetes is excessive birth weight. And of course, I don't know if you remember, but having a baby over 9 pounds increases your risk of becoming a type 2 diabetic later on in life. We can have a preterm birth and respiratory distress. Baby might be born with hypoglycemia. They may be, like we said, a macrosomia, which is just a large baby. Having gestational diabetes can also increase your risk for high blood pressure. And so if you have an increased risk for high blood pressure, then you're going to have an increased risk for preeclampsia as well. Okay, so who gets screened and why? Well, really every mom gets screened, but especially if you have a BMI pre-pregnancy that was greater than 30, or if you have a first-degree relative who has diabetes, then before they even think about testing for gestational diabetes, they're just going to test and see if you have diabetes in general. So, if you're at the average risk, then you'll still be screened in your second trimester between 24 and 28 weeks of pregnancy. So, during testing, they do the glucose challenge test, and this is where you drink this really sweet, syrupy glucose solution, and then 1 hour later, they're going to test your blood sugar and see what it is. So, if your blood sugar is below 130 to 140, then that's a normal challenge test. But if your blood sugar level is higher than that, then it just means that you have a higher chance of developing gestational diabetes, and you probably need a follow-up glucose tolerance test where you fast overnight and have your blood sugar measured, and then you drink the sweet syrupy solution again that has an even higher concentration of glucose. And then they check it every hour for 3 hours. And if at least 2 of the readings are higher than normal, then you're going to be diagnosed with gestational diabetes. So, things going on with mom are maternal effects of gestational diabetes. It increases your risk for urinary tract infections. Why? Because we've got that nice sugar-rich blood, and so that's going to promote spilling of glucose into the urine, and so there you're going to have all that glucose in the urinary tract, and if there's any bacteria there, then they're going to grow and multiply. The next thing that can happen is the hydramnios, which is actually where you have an increased amount of amniotic fluid. You can have a premature rupture of membranes, and you also are at higher risk for preeclampsia. So here are our risk factors. We talked about some of these. Overweight, they say BMI greater than 25. Some places I looked, especially the Mayo Clinic, said higher than 30. Maternal age older than 25, previous gestational diabetes, history of abnormal glucose tolerance level, history of diabetes in a first-degree relative, or if you're a member of one of those high-risk ethnic groups that I stated before. So what can we do? Well, the first thing that's going to have to happen is mom's going to have to eat a healthy diet. And eating the right kind of foods in the right portions is the best way to control blood sugar and also to prevent too much weight gain. So, a healthy diet is going to be fruits, vegetables, whole grains, foods that are high in nutrition and fiber and low in fat and calories. We have to instruct mom to limit those highly refined carbohydrates and sweets. And remember, there is no magic diet that's right for everybody. We have to look at what mom's normal diet is, and then from there make recommendations for changes so that we can make sure we get all the nutrients and we're not getting too much sugar and too many refined carbohydrates. The next thing is exercise, and of course we hope that mom is on an exercise regimen before she gets pregnant. That would be the best thing, because exercise lowers your blood sugar level. It also helps your cells increase sensitivity to insulin, and it can help with some other common discomforts of pregnancy like back pain, muscle cramps, swelling, constipation, trouble sleeping, and it can help mom get into shape for the hard work that she's going to go through during labor and delivery. But remember also, we have to make sure that it's okay for mom to be doing whatever exercise she wants to do. So the doctor is going to say, yes, it's okay, or you may want to start small and work up. It just depends on how active she is before she gets pregnant. We also want to make sure that we keep a close eye on baby and that we monitor baby's growth and development with ultrasound and other tests. We also want to watch and make sure mom goes into labor by her due date or earlier. And if you have gestational diabetes, your doctor or the doctor may induce labor to help decrease the risks that are associated with gestational diabetes. And the big thing is having a large baby as well. Okay, so question. During a prenatal visit, the nurse is explaining dietary management to a woman with pre-gestational diabetes. The nurse evaluates that teaching has been effective when the woman states, I will need to eat 600 more calories per day because I am pregnant. I can continue with the same diet as before pregnancy as long as it is well balanced. diet and insulin needs change during pregnancy. I will plan my diet based on results of urine glucose testing. So the correct answer is C. Diet and insulin needs change during pregnancy. That first one, I need to eat 600 more calories per day because I'm pregnant. Well, if you're already eating 5,000 calories a day, we sure don't need to add 600 more to it. B, continuing with the same diet before pregnancy as long as it's well balanced. Well, that may or may not be true. We may have to add some stuff to it or take some stuff away. So it's not always going to be that. And then we can't plan a diet based on urine glucose testing because that doesn't occur all the time. Okay, cardiovascular disease. It's normal for changes to occur because mom is supporting two people and not one person. So if she already has cardiac disease, then that can cause decompensation in the mom. So our goal is to manage the heart disease and prevent the development of congestive heart failure. So if you need to review congestive heart failure from last semester, I would advise you to do that. Intrapartum and postpartum management focuses on preventing fluid overload. Because remember, we're going to be giving IV fluids and we're going to want to make sure she's hydrated, but we got to make sure we're not giving her too much and she goes into fluid overload. So signs and symptoms of heart failure, once again, this is a repeat from last semester. It's the same as with any other person with congestive heart failure. You can have right or left-sided heart failure, cough, progressive dyspnea on exertion, orthopnea, that's going to be left-sided heart failure, and then pitting edema of legs, feet, face, hands, and sacral area is going to be right-sided heart failure. They may have heart palpitations, they may have fatigue or syncope with exertion, and they may have those rails, those moist rails in the lower lobes that could be indicative of pulmonary edema. Alright, anemias, and this is the most common problem with pregnancy is anemia. Iron deficiency causes 75% of anemias in pregnancy, and it's difficult to meet pregnancy needs for iron through diet alone. Most of the time they have to have some type of supplement in order to meet the iron needs. We can also have a folic acid deficiency. And remember, folic acid is associated with those neural tube defects. So, and those neural tubes are forming and fusing early in the pregnancy. So if mom comes in and she's already 3 months pregnant, then there's not a whole lot we can do for what's already occurred if she hasn't gotten enough folic acid in her diet. And normally we do have to give supplements in order to treat the folic acid deficiency. Now, there are some other anemias such as sickle cell, and we know you should know what sickle cell is. We learned that last semester. And sickle cell episodes get worse as pregnancy changes occur. So our primary goal is to prevent sickle cell crisis during pregnancy. Thalassemia, we learned about this last semester too. So we would want to make sure that we give them plenty of iron. But remember that increased iron absorption and storage make the woman susceptible to iron overload. And also, iron causes women to be constipated. So we have to watch when we're giving these iron supplements and make sure that we are doing something about the potential for constipation as well. Okay, some immune diseases that may cause problems. Lupus, and lupus is a chronic inflammatory autoimmune disease where the body produces antibodies against itself. Antiphospholipid syndrome, and this is a cluster of entities associated with increased risk for thrombosis, fetal loss, and low platelets. And this has to be treated. We normally treat this with a low-dose aspirin, enoxaparin or Lovenox, and heparin. Okay, Hashimoto's thyroiditis. This is just an autoimmune disorder where the body attacks the thyroid gland. And because of this, it increases the risk for miscarriage. So mom should have TSH evaluation every 4 weeks for the first half of her pregnancy, and then once somewhere in between 26 to 32 weeks. Okay, seizure disorders, epilepsy. Of course, we must continue to manage mom's epilepsy while she's pregnant. We can't just take her off of her medications. But a lot of anticonvulsants will harm the fetus. So we may have to change the anticonvulsant medication while mom is pregnant so we can prevent these negative effects. So when mom has a seizure, this can result in fetal hypoxia, acidosis, and this in turn can cause serious problems for the fetus. Okay, infections during pregnancy, they can have devastating effects on the fetus. If you look on page 624 and 625, table 26.2, it lists all of these and it tells you all about each one. The important thing is that we need to find out whether or not mom has been immunized for these diseases. HIV could be a concern as well, because there is greater than 30% chance that mom can give the virus to her fetus. So we need to make sure that if she actively has HIV, that she is being treated with zidovudine along with other antiviral medications to help reduce the chance of infecting the fetus. And then once the baby's born, we have to start them on the medication as well. Some non-viral infections, toxoplasmosis, we know this is the cat litter and raw meat, so we would need to educate mom on those dangers. Group B, strep, is probably the biggie. It can cause life-threatening perinatal infections. It can be transferred to the newborn during a vaginal delivery. So normally we test mom at between 35 and 37 weeks. We treat her with antibiotics, and to prevent transmission, she may have to have a cesarean. TB, perinatal infection in the United States is rare, but it can occur. But you just need to know and be aware of tuberculosis and how it's transmitted, and make sure mom knows what signs and symptoms she may need to look for in family members, especially if we have people living in really close quarters, a lot of people that may not be very hygienic, or you have people who are sick. We would want to assess for situations like that. Okay, that's it for this lecture. We will talk about Chapter 27, Intrapartum Complications, when we do the intrapartum lecture. Thanks.